analyst at the Oregon Health Authority Health Systems Division, and this is the second webinar in a series designed to provide CCOs and subcontractors information about mental health parity. The focus of this presentation today regards non-quantitative treatment limitations, or NQTLs, and there will be some other discussion of the handouts that you've received. So we're going to start with the presentation itself, and as time allows, provide some information about the handouts. So today we're going to cover the an overview of NQTLs, look at the overall parity setup, which will be review some material from webinar 1 that I think is important to consider. We're looking at the overall analytical framework for NQTLs, and then look at the parity analysis itself. So looking at the overview, there are some definition examples that I think will be helpful, and starting first with the NQTL definition. And NQTLs, or non-quantitative treatment limits, are limits on the scope or the duration of benefits, such as prior authorization or network admission standards. NQTLs can also be soft limits on what might otherwise be a quantitative treatment limitation, and these allow some flexibility in the application of numerical limits. Some examples of NQTLs include medical management standards that limit benefits, and these are based on medical necessity or appropriateness criteria, standards for provider admission to participate in networks, the reimbursement rates themselves, restrictions based on geographic location, fail first, and exclusions based on failure to complete a course of treatment. So some of the examples to expand on that, again, relate to medical necessity criteria development, the practice guidelines selection, medical appropriateness reviews, exclusions, fail first requirements, and step therapy protocols. NQTLs cover a broader set of restrictions as well. These can include service reimbursement methodologies, and this really applies to how various provider types are reimbursed under different services, mental health versus medical surgical. Familiar NQTLs would be authorizations, prior authorization, concurrent review, retrospective review. And it's important to remember that there may be other limitations on the scope or duration of benefits outside of this example set. We're really looking at operational parameters that limit the access of a given service or treatment to mental health or substance use disorder diagnosis and treatments. So let's look at the parity analysis setup itself. And here we're stepping back and summarizing some of the information, webinar 1, that I think is helpful to set the frame for the NQTL analysis as well. So reviewing the parity analysis setup itself, reminding you that parity analysis is conducted on OHP plus benefits, that's BMH and BMP, and we're looking to distinguish between treatments that apply to medical surgical versus mental health substance use disorder. And that parity analysis is based on conditions as defined in ICD-10, Chapter 5, the F codes, and this is based on condition, not on provider type. So this parity analysis overall is conducted within each benefit classification, and those are defined as inpatient, outpatient, emergency care, and prescription drugs. And the parity analysis is conducted across delivery systems within each CCO, including subcontractors. So that's sort of a punch list of a couple things I'm going to be covering over the next couple of slides, so a little more detail as we move forward. So first, the idea that OHP plus is the area of analysis. So that includes Medicaid, CHIP, and ABP, ACA. So again, this is the BMP and BMH services, and we're looking specifically at Medicaid, CHIP, and the ABP for the ACA expansion. So in the state of Oregon, these are all defined using the same criteria, so we'll be analyzing them together in a bundle. So in the setup analysis process, there are 3 steps that are going to come up. The first is assigning benefits to a med-surg or mental health substance use disorder benefit type. So is it mental health, or is it med-surg? And there are some guidance in terms of how that division is going to be applied. Second, there's assigning these benefits to inpatient, outpatient, emergency, and prescription drug classifications. And we'll see why that's important in a minute. And then the third step is to evaluate the CCO using, looking at the CCO delivery system, including subcontractors, and some more detail on that in a moment. So the first step is to identify med-surg and mental health sub-benefits. And the definitions are in the final rule, but simply put here, we're looking at medical surgical benefits, and these are services that are related to diagnoses as defined in ICD-10, and specifically med-surg excludes the ICD-10 Chapter 5 diagnosis group. Mental health benefits are defined under ICD Chapter 5, the F codes, and substance use disorders also comes under Chapter 5, and there's a division set between those in terms of whether or not the condition is substance use disorder or mental health. So an example, and this is really an important point, this distinction is based on diagnosis and not provider type. So you may have a service delivered in what we think of as a medical provider type, but in fact it is being assigned to a diagnosis or a service that is related to mental health, for example. So here we're looking at the idea that ICD-10 classifies anorexia nervosa as a mental health condition, and therefore in this instance, nutritional counseling for anorexia nervosa is assigned to the mental health benefit type. Now, the second part of this is assigning these mental health and med-surg services to 4 benefit classifications. So the parity requirements for QTLs and NQTLs follow this pattern. So the rule identifies these 4 classifications, again, inpatient, outpatient, emergency care, and prescription drug, and that's going to be a fairly familiar set by the time we're done with this presentation and this process. This is the fundamental breakdown of the different service types. I wanted to point out that under outpatient, it is allowable to break outpatient into 2 smaller categories, office visits and other outpatient services, and we'll provide some guidance about that. What I do want to point out at this point, and you don't need to pull it out because there's a lot of information there, but I want to preview to you the mapping guide that has been provided to you. So just an overall introduction, and then we'll continue with the presentation. So we have provided a guide to mapping Oregon Medicaid benefits and services, and understand that this is an internal document that we've developed for analyzing fee-for-service services. And really what we're doing is looking at how Oregon Health Authority understands the division in terms of mental health SUD and also the different categories or classifications, outpatient, inpatient, et cetera. So this guide maps individual treatments into a grid that cross-tabulates the med-surg, mental health, and substance use benefit types, and a cross-pattern with inpatient, outpatient, emergency, and prescription drugs. And this bucketing guidance provides a basis for the analysis of parity between mental health and med-surg, and between substance use disorder and med-surg. And those are the comparisons that we'll be looking at in terms of assessing parity. So looking at the structure of the guide itself, basically we have this familiar list of classifications, inpatient, outpatient, et cetera. And we're also looking at a breakdown between med-surg, mental health, and substance use disorder diagnosis and specifically treatments. And so the boxes provide the framework for parity analysis. Now looking at the uppermost left box, we're looking at the intersection between inpatient and med-surg. And these are treatments that are sorted by diagnosis, and we're looking at inpatient services. And that would include things like room, lab, anesthesia, surgical procedures, that sort of thing. And as we move down that column to the inpatient cross with mental health, we're looking at mental health diagnosis and treatments, and we're looking at inpatient services, including the same sorts of things. Really, these can be certain procedures and services can be any one of the three, and it just depends on the diagnosis. So looking at this mental health and inpatient services, we have familiar things like room and lab and other typical inpatient services, but it also includes inpatient psychiatric services and rehabilitation. So it has some specificity to mental health, but it also can include more generic services and ancillary services as well. And then just to round out the column, we're looking at the same sorts of inpatient services, room, lab, et cetera, but substance use disorder would add things like detoxification and residential SUD services. And then the same would apply as you run down the outpatient and emergency care and prescription drug categories. So we're really looking at, if you look at, again, the column, we're looking at mental health for inpatient as compared to mental health or med-surg for inpatient. And I think that comparison for Parity will become clearer as the presentation continues, but I just wanted to give you a view into that resource. So the third part of setting up for Parity analysis is to look at the CCO delivery system itself. And so Parity analysis must include all CCO operations, including subcontractors that provide med-surg, mental health, and SUD services to its members, and set or apply policy for treatment limitations. And that pair of words, set or apply, is going to be really important. It's how the limitations are created, and also how they are applied in practice. And in terms of looking at the CCO delivery system, then we want to pinpoint the parts of the delivery system that are subject to Parity analysis, including, and this is key, is all organizations within the CCO group that set and apply treatment limitations. So that includes the CCO itself. It may include mental health organizations, independent practice associations, county mental health programs, and other subcontractors that are involved in service provision. So here is an example and a way to think about this. As you identify combinations of organizations that create delivery systems, we're thinking about different service areas as being different delivery systems, and different combinations of organizations. So it may be that a CCO has several different organizations that it subcontracts for different parts of the service. So those may be, each of those combinations may be considered a separate delivery system. And the other part is to realize that CCO may set policy for NQTLs, but subcontractors may apply NQTLs to members residing in the service area. So here, an example on the right side of the slide is looking at a CCO that has contracted some of its mental health services out to CMHP, and that's divided by county. So in this instance, a separate Parity analysis will be conducted on the two unique delivery systems, the CCO plus County 1 and the CCO plus County 2. And that would be two separate analyses because the subcontractors may be setting and applying in operation the Parity, the processes in a way that is different under Parity analysis. So I'm turning to Leah Forstman, and Leah, if you would introduce yourself and move into the analytical framework itself.
Hello, everyone. Now we're going to take a little closer look at the actual NQTL rule and explore in more detail the concepts of comparable to and applied no more stringently than. So the actual rule states that NQTLs cannot apply to mental health SUD benefits in any classification unless, as written and in operation, any processes, strategies, standards, and other factors used in applying the NQTL to the mental health SUD benefit are comparable to and applied no more stringently than those used in applying the same NQTL to med-surg benefits in the classification. So there's a couple of terms that we'd like to focus your attention on in this regulation, and they're highlighted in bold on this slide. Comparable to and no more stringently than are the burden of proof that we have when comparing NQTLs across the mental health SUD and med-surg benefits within each classification. So this schematic highlights the NQTL's comparable to and no more stringently than conditions, and it essentially divides the NQT analysis into two parts. So first you're going to evaluate the comparability of the process, standards, strategies, etc. And then you're going to evaluate the stringency with which the processes, standards, strategies, etc. are applied to the benefit. So the next two slides contain a list of questions that CMS has shared that can help determine whether or not an existing NQTL placed on a mental health SUD benefit can be considered comparable to those placed on the med-surg benefit in a particular classification. And there's a couple things to keep in mind. The first is that these questions ask about specific details in regards to a single NQTL type. So these questions will need to be asked for each NQTL type that's identified in their respective classifications. Also remember that NQTL types will be compared across a classification rather than compared service to service. And just as a reminder, the classifications are inpatient, outpatient, emergency, and pharmacy. So if we look more closely at the questions, starting on this page, they'll ask some fairly specific details, such as what are the NQTL requirements, what's the definition, and under what circumstances would the requirements be applied. Next slide. Other questions to consider might be how often are the medical necessity and appropriateness criteria updated, and what's the purpose of applying the NQTL. So this is a CMS example to demonstrate the comparability principle. And in this example, members can obtain an inpatient treatment for eating disorders in an out-of-state facility when there is no in-state bed available. In addition, this NQTL is based on national practice guidelines, and it's intended to facilitate family involvement, which are all good things. However, this benefit falls short when compared to the med-surg NQTL, and that's because there are no limits at all on out-of-state treatment for med-surg conditions, but there are for the mental health condition. So this NQTL would need to be remedied or eliminated in order to comply with the mental health parity requirements. Next slide. So now we're going to switch gears, and we're going to focus on the other NQTL condition, which is stringency. And the next three slides have a list of questions that can help you determine whether or not the NQTLs on your mental health SUD benefits are no more stringent than the NQTLs on the med-surg benefits within a classification. So these questions are focused on any consequences or penalties that might apply if the NQTL is not met, what level of performance is required to meet the NQTL requirements. And this slide shows what standards form the basis of the NQTL requirements, such as benchmarks and any standard thresholds that may apply. And finally, what procedures are used when applying the NQTL? Are there any exception processes, for example, or how much discretion is allowed, etc. So this is a CMS example to demonstrate this stringency concept. In this example, we have a subcontractor that's administering the mental health SUD benefit, and the CCO is administering the medical surgical benefit. The subcontractor permits coverage of out-of-state mental health SUD inpatient treatment only when an in-state bed is not available. However, the CCO makes exceptions for certain med-surg conditions when the out-of-state facility is a center of excellence. So if the subcontractor makes no exceptions, then the NQTL is more stringently applied to the mental health SUD treatments than to the med-surg treatments. And that means that this particular NQTL would need to be either eliminated or remedied in order to meet mental health parity requirements. So we've talked now about the NQTL rule itself, and we've focused specifically on the comparability and stringency principles. We've reviewed some questions that will help you determine whether your benefits pass the comparable to and the no more stringent than test. And we've seen some CMS examples. And so now I'm going to turn it back over to Jason, who is going to take you through the actual steps of the NQTL analysis.
Great, thanks, Leah. So now we're moving into the NQTL parity analysis itself, and we'll be working through a step-by-step approach to addressing that. So looking at the chart here with the 3 steps to the parity analysis, what I'd like to do is set up and begin to look at the step-by-step process here. Looking at the parity process itself, we want to highlight these steps, and the first is identifying relevant NQTL types, and this comes from identifying limitations that are applied to specific services. And in doing this, we can identify the NQTL types, such as pre-authorization. These types of NQTLs can be identified from written rules as well as operational guidelines providing different services. And once these NQTL types are identified as being operative in a particular classification, then we go to collect information about each NQTL. So we want to understand how the NQTL is applied to different services within a classification, and then to analyze the overall pattern of NQTL applications, such as prior authorization, and look to remediate NQTLs that are not in line or consistent and bring them into parity. So that's a lot of material to cover in a single slide, and so let's break it down into the steps. So step 1 is to identify the NQTL types applicable to mental health SUD services. So we want to look at NQTLs applied to any mental health or substance use disorder benefits within the 4 classifications. What we want to then do is understand that some of the NQTLs may be readily identifiable, such as medical management standards and requirements for admission to provider networks, but other NQTLs may be embedded in the service delivery system managed by the CCO, especially operational factors related to the application of NQTLs. So we're, again, looking to go from the individual level of individual services to build up to a particular or a set of single NQTL types that are then analyzed by category. So the second point here is, I think, the one that we want to pause on for a moment. NQTL analysis is conducted at the level of classification. It does not require a one-to-one comparison of a mental health SUD service to a similar med-surg service. So let's look at that, how that works in terms of collecting information. So the second step in analyzing NQTLs is collecting information for each of these limitations. So again, using prior authorization as an example, we can dig into this. We want to collect information and documentation on all the factors used in applying the NQTL PA, for example, to mental health benefits versus med-surg benefits in that classification. That would be like outpatient. We want to look at the processes, strategies, evidentiary standards, as well as operational factors in the application of prior authorization in mental health versus med-surg benefits. So the idea is that we're looking at the written standards and operational processes for each service to see if NQTLs apply, and we're creating a list of NQTLs. Yeah, we're looking at a list of NQTLs that apply as a type within mental health and SUD benefits, say the inpatient, the inpatient category. That list shows that pre-authorization, for example, applies to mental health SUD outpatient classification, and we'll need to look at overall how that limitation type is applied to mental health SUD benefits, and then look at that relationship to med-surg benefits. So here we're looking at the types of information we want to collect about each service, as it relates to an NQL type, and then looking more broadly at the type itself. So the kinds of things we want to look at in researching services and NQTLs is one, as Leah had pointed out, to analyze comparability, and questions we might ask of a particular service and of the NQTL type more generally is, what is the purpose of applying this NQTL to the benefit? Is it, for example, related to a national standard or guideline, or is it more arbitrary to the operation of a particular organization? Under what circumstances is this NQTL applied? What evidence supports the assignment of this NQTL to the benefit? And then in looking at stringency, we want to look at the consequences or penalties that apply when the NQTL is not met, how much discretion is allowed in applying the NQTL, and how difficult it is to meet the requirement. And we'll be looking at the variability and how that plays out in the actual operations of the medical organization. So just to highlight, and we want to make sure we catch this, the benefits are mapped to inpatient, outpatient, et cetera, these classifications, and the analysis of parity occurs within the classification. For example, within outpatient, we're looking how mental health benefits are treated versus med-surg, and we're conducting the analysis at the level of the classification. And again, we don't require a one-to-one comparison of mental health versus a corresponding med-surg service. We're not trying to map across for specific equivalencies. So now we're going to the overall NQTL review. And we're highlighting that we're looking at the decision-making process, the process of how decisions are made in terms of creating or defining a limitation, and also decision-making on how that limitation is applied in practice. So the objective here is to show that policy formulation and operational decision-making need to have comparable processes and refer to standards that are no more stringent for mental health than for med-surg. So we want to ensure that CCO, mental health, and med-surg NQTLs are established using a comparable methodology and referring to generally recognized independent standards of medical practice. And I think that bullet point, comparable methodology and referencing independent standards, defines the gold standard for understanding the level of parity. This is a process question, not an outcome question, and we'll talk about that a little bit in the next couple of slides. In addition, then, operational decision-making must be conducted using processes that are comparable and consistently applied across CCO delivery systems. Variability is itself an evidence of a lack of parity. So questions to ask during the NQTL review, some of these questions relate to the criteria for setting an NQTL, and we want to check to see if NQTLs are not comparable and require more analysis. So we want to understand the purpose of applying an NQTL to these benefits, and the idea here is this for the convenience of or for other reasons than best practices, a regular and predictable process and external standards. So what are the standards that form the basis of the NQTL? Are they recognized by the national practice, or are they more ad hoc? Is the rationale for applying the NQTL to mental health sub-benefits supported by evidence? Does the application of the NQTL include similar components for med-surg benefits and mental health sub-benefits in writing and operation? And these speak to the process as well as the formation of the standard. Some additional questions to ask to get to that application side. The questions identify factors that relate to applying NQTLs, and the issue is, are they more stringent for mental health sub-benefits? Is it harder to pass the NQTL for mental health sub-benefits than it is for med-surg? Are the consequences more severe for failing to meet the NQTL when it applies to mental health sub-benefits? Are there differences between the application of NQTLs to mental health benefits when they are different, are these differences arbitrary? Are the differences consistent with practice guidelines? Good. So we're now looking at, in terms of that, at the level of discretion that line providers in the review process allow, and how difficult it is to meet the requirements. And here we're looking at the difference between the structure itself and also the way that the limitation is interpreted in operation. And the concern is that if there's a great deal of variability and stringency in the application of limitation, then it's hard to say that there's parity because of that variability. Oh, I'm sorry, go back one. Good. So a major takeaway is that the non-quantitative treatment limitation results do not need to be the same, med-surg versus mental health. Compliance depends on how each NQTL is set and applied. Again, that gold standard. The final rule requires that there is a parity of factors, standards, processes used to establish the NQTL, and parity of how the NQTL is applied in practice. Again, looking to the example of prior authorization, using PA for mental health benefits may still be permissible even if PA requirements lead to higher denial rates for mental health services if there are no arbitrary or discriminatory differences in how the NQTL is applied. To summarize again, establishing parity in the setting of and applying of particular NQTL types includes documenting the standards and evidence used in setting the limitation, factors in defining the process for the application, and operational processes for applying the limitations consistently. The evidence does not need to be the basis. The evidence provides the basis for establishing parity, not the outcome. For example, again, prior authorization, the denial rate may be higher for mental health as long as the limitation of the applications are comparable and no more stringent in application. The real question is not the outcome, but the process. The good news is that the clearest way to show compliance on NQTLs is first, when a specific type of NQTL is not employed for mental health services at all. And second, when a comparable standard was used to make and apply a type of NQTL to both med-surg and mental health benefits. So if the limitation was created using a comparable process with reference to a national practice standard, and note here that it may in one instance apply or call to a medical standard, in another case a mental health standard, not the same standard, but the point is that we are calling to the relevant national standard in formulating the NQTL, and the structure of applying the NQTL is not more stringent in its application to mental health versus med-surg, then this analytical process and the documentation with it show that the NQTL is applied with parity. So as we move off of that gold standard, and I think we just need to pause on that, it's process rather than outcome. It's standards and evidence and consistency rather than particular levels of denial rates, et cetera. So I want to now just turn to close out the presentation and talk about some of the timelines and resources that are available. So the upcoming webinar 4 will deal with documentation and some of the different aspects of creating documentation for QTLs, NQTLs, and other aspects for October 2nd. Then on May 15th and 19th, really, we have that set for another set of one-on-ones. But if you reach out to me, I can set up one-on-ones most any time that you are interested in checking in with us. The format of that is to provide questions to us in advance that we can research and come back with a more set response in terms of guidance. Once we have questions for you, then we can set a time to do a phone conference and address those questions. I should also say that in terms of the one-on-ones and really all of the interactions we have, collecting questions from the webinar, getting questions via email, collecting questions as a function of the one-on-ones, those questions then and the responses that we generate will fall into a series of FAQs. And we'll try to get those out fairly efficiently rather than pulling together a large chunk at a time. Again, looking at the future webinars, the next two webinars, webinar 4 and 5, we'll be looking at question and answer topics that we want to treat based on some of the information that we're able to share. And we'll also provide a forum for troubleshooting and sharing among the different CCO groups. And we'll see how that plays out. But that's the format for the webinar on May 18th. Also want to highlight the deadlines. May 19th is the QTL deadline for CCO analysis, and June 23rd is the due date for the NQTL analysis. So again, to highlight some of the resources that we're providing, there is the webinar itself, the one-on-ones, and again, contact me to set those up, the mapping guide, which we'll share in a moment, the QTL worksheet that we will share in a moment, and the NQTL worksheet, which is upcoming. In addition, the CMS resources that we've identified that might be useful. Again, as I've said before, this material is fairly dense and is sort of pitched at the state rather than at the CCO. So in some cases, it's a little bit opaque, I guess, and our role really is to bring that down and provide useful information about how that applies to the Oregon system. So again, if you have questions, please send them directly to me, and we'll do our very best at providing timely responses. And what I'd like to do now is to take a look at some of the resources that we've developed. So there are two items here. One is the Guide to Mapping Oregon Medicaid Benefits and Services, which I previewed in the presentation in terms of the rationale about why it was set up. But I'd like to provide you some more background about how it was developed and how it might be useful.
This is Jesse Anderson. I'm the State Plan Manager for the Oregon Health Plan. In developing this mapping guide, we started with defining the 4 classifications in the regulation. Since we didn't have any of the definitions currently in our Oregon administrative rules, we looked to the Medicaid Code of Federal Regulations and used those as they were broad-based definitions and consistent with our programs. The next step in the mapping was to bucket all of our programs and services into each of these 4 classifications. To do this, for fee-for-service, we first looked at the categories of service as they were laid out in the state Medicaid plan. The state plan for Medicaid that I referred to is a document that CMS must approve for all Medicaid states. For us, it's approximately 900 to 1,000 pages, and it outlines the agency structure, the eligibility groups that we've chosen, and any mandatory or optional services or programs. Secondly, we looked at what we refer to as the bucket book groupings that we've used for many years in the capitation development process to keep the groupings consistent with what has been used in the past. And of course, all of these groupings and names are what we utilize in fee-for-service, and the CCOs may have different acronyms and different names for their programs or different groupings, but it gives you an idea of what in fee-for-service, based on our program types, what we've done.
Okay, and so then this maps onto, I think it's a sort of fairly familiar layout versus what was laid out in the presentation. We're breaking out across the top of each of these inpatient, outpatient, prescription drug, and emergency care. And notice that we've laid this out according to the medical surgical map, and that goes on for 2 pages, and of course outpatient is the largest category there. And then we look at mental health in Table 2 and substance use disorder in Table 3. And the logic throughout is comparing, using medical surge as one part of the comparison, and then comparing that either to mental health or to substance use disorder based on the classification. So again, inpatient med-surg as compared to inpatient mental health or substance use disorder. This guide provides some additional information in terms of definitions that are related to the classifications, as well as some additional CMS resources that were specifically included in creating this guide. The second item that I want to highlight to you here, yes, is a form that we put together to reflect our experience in the QTL analysis process. So our fee-for-service has a little bit different flavor in the sense that for fee-for-service, we have a single entity. So we don't have for CCOA and CCOB, we don't have different subcontractors. The state under fee-for-service is its own, in a way, its own CCO. So when we looked at that and looked at how that relates to how the operations of a typical CCO, we understood that there may be different subcontractors that are involved. And going back to the idea of CCO delivery systems, understanding that the CCO operations in conjunction with, if you recall the chart, a county A and county B, each of those, CCO plus county A, CCO plus county B, establishes a separate delivery system. So this worksheet, the first part, lays out a process for cataloging different contractors, understanding what their service responsibilities are and how they relate to different classifications of service, inpatient, outpatient, et cetera, as well as the responsibility for QTLs and NQTLs. So there's a lot there, but it's focusing in service area in this delivery system category, looking at the different contractors and understanding their service responsibilities in mental health, substance use disorder, and med-surg. And then they also wanted to look at the same breakdown in terms of regions or areas. So again, we're looking at the contractors and responsibilities, but we're breaking that out in terms of different regions, say Clackamas County versus Multnomah County. So that page 2 gives you an idea of a form to note that activity. And then the part 2, which is the mental health and such QTL inventory, is a format for capturing QTL types and levels, in this case a visit limit versus the number of visits. And this really refers, if it seems unfamiliar to this presentation, the description of the QTL analysis was in webinar 1, and you might want to take a look back at that. But this is essentially doing that categorization of QTL type and level and its application in terms of what procedure codes it might relate to, and its relation in terms of inpatient, outpatient, or emergency care. And here's the this third, or this extreme right column, plan to keep. As we were discussing QTLs, it was fairly clear that having the basis for keeping a QTL is fairly slim. That the 2-part test is pretty high bar to pass, and in most cases, QTLs will probably be eliminated or converted to NQTLs. So this is a way of understanding what QTLs are there, where they apply in terms of the classification, and whether or not they'll be converted or eliminated. And I would suggest that the plan to keep column will probably almost always be no. It will either be eliminated for mental health SUD, or converted to an NQTL. And we're looking toward compliance, and ultimately we either have to prove that you can keep it using the 2-part test or eliminate it. So there's a lot of information under the third part, the two-part test, and I don't want to go into the structure of how that is set up. I think this captures the logic of the two-part test, but it's fairly involved, and I hopefully you in most cases won't find it necessary to delve into that level of analysis. And so, and then we have a remediation plan in terms of how to fix QTLs that need to be eliminated. So hopefully this is a framework that allows for an orderly evaluation of QTL. And what I also want to then share with you is that we will be giving you a NQTL analysis framework as well. We're working on that now and working through the approval process, making sure that we're comfortable sharing that with you. And just to underline that these guides and worksheets are provided to assist you in your analysis. We're not mandating the use of this particular form in any particular way, but we want this to be a good reflection of the work that we've done internally and also the work that we've done in terms of analyzing the CMS guidance to make it more useful and user-friendly as you dig into your own analysis. So those are the main objectives for this meeting. We've gone over the NQTL process. We've done some work to review the QTL analysis, and we've highlighted some documents and tools that you can use to address your own internal analysis. So we will be looking to hear from you in terms of questions that have emerged from this presentation, as well as your needs across the board. And we'll look forward to seeing your questions and talking with you in a variety of formats as we continue the process of supporting the implementation, your implementation and our work in getting the parity analysis process done and behind us. So thank you for all of your good work, and we look forward to talking with you soon about moving forward with this.